Good morning, dear students. So today I'm going to talk about neonatal resuscitation. This is a very important practical lecture. Now, in the beginning, what do you mean by neonatal resuscitation? Now, neonate are the babies who are just born or up to 28 days of life. And resuscitation means if they are born with some problem, for example, they are not breathing, their heart rate is too slow, their color is blue or very pale, or they are not moving, they are very hypotonic, then we need to resuscitate them to bring them back to the normal life. Okay, probably we give some ventilation, we give oxygen, we give cardiac compression, we give medication. All these things are called resuscitation. So it has a particular pattern. Now, in the beginning, let me talk about what is the importance of neonatal resuscitation and which type of babies, okay, need neonatal resuscitation the most. Now, look at this old health report. Okay, now we focus on the neonatal cause of the death. Here, among all babies, okay, 37% of the mortality is because of neonatal cause. Now let's analyze that neonatal cause here. What are responsible? Preterm birth 28%, severe infection 26%, and birth asphyxia 23%. The majority among all. Okay, and the rest of other, like see here, neonatal tetanus 6%, congenital malformation or anomaly 8%, diarrhea 3%, and other which are not classified here 7%. Now, what I like to highlight here is look at this birth asphyxia one. 23% of the mortality in neonatal age group is because of birth asphyxia or hypoxia at the time of birth, and a good resuscitation at the time of birth can probably save those babies. That is the importance of neonatal resuscitation. Not only birth asphyxia, but even preterm baby need resuscitation at the time of birth. Even congenital anomaly, some of them may need resuscitation at the time of birth. Now, what is that resuscitation? Let me give you insight in the beginning so that whole topic would be very easy for you. Now, see here, we assess a baby's response to birth. Okay, we assess baby's response to birth. Now, that is done by Apgar scoring. After birth, at 1 minute and 5 minutes, you evaluate Apgar score. APGAR Apgar. So A, appearance, P, pulse or heart rate, G, grimace, A, activity, R, respiration. Isn't it? So you evaluate according to that, you give certain score. If the baby's Apgar score is more than 7 at 1 minute, you don't need to worry anything. That baby is healthy, the baby is all right. If it is less than 7, then you need certain resuscitation, probably the minor ones, if it is more than 5. But less than 5 or less than 3 is a very severe one. So we need proper resuscitation. Now, see here. So after the birth, we keep that baby warm. Okay, immediately remove that wet linen from the baby, wrap the baby with warm cloth, position and clear the airway, and stimulate to breathe if the baby was not breathing or baby was not crying. Just rub the back gently, flick the sole, okay, and then give oxygen. Now see here, this type of resuscitation are always needed by the newborn. We consider them as a routine phenomena, a routine process inside the delivery room. Now, after that, some of the baby may need bag and mask ventilation or even endotracheal intubation. Now, what type of baby need that? If the baby is not breathing, okay, even after minor type of resuscitation, if the baby is not breathing, then you have to go for bag and mask ventilation. Okay, establish that. And if that is not effective, you go for endotracheal intubation, then continue with bag and mask. Sorry, continue with ambu bag ventilation. Now, mask is not necessary once you put endotracheal tube. Now, these are needed less frequently by the baby. Another step in resuscitation is chest compression. Now, if the baby's heart rate is consistently less than 60, then we provide chest compression. Okay, and I forgot to mention the indication for bag and mask ventilation, because we are going to discuss later on all about this. But right now, I like to highlight here, if the heart rate of the baby is less than 100, or if the baby is not breathing, then we go for bag and mask ventilation. Now, this chest compression and these medications are rarely needed by the newborn. They are advanced type of resuscitation, and very experienced, doctors should be there or nurses should be there. And these medication which are necessary at the time of resuscitation are adrenaline or epinephrine, the most important among all. Atropine is also important there. Then dextrose, okay, 5% or 10%. 10% dextrose is very commonly used at that time if necessary. Then sometimes even lidocaine, sometimes even sodium bicarbonate, sometimes even calcium gluconate, sometimes even naloxone. So all these according to the situation. Now 90% of the birth, they don't need any assistance, 10% some assistance, and 1% need extensive assistance or resuscitation at the time of birth. And one more point we like to highlight here. Now see there, out of the 5 million deaths per year, 1 million deaths are because of birth asphyxia, and that can be prevented by effective resuscitation. So this is a very, very important knowledge for all of us. Now, what do you mean by asphyxia then? Now, asphyxia means it's a combination of hypoxia and hypercapnia together. Hypoxia, okay, there's decreased oxygenation in the tissue. Hypercapnia, increased carbon dioxide collection inside the body. Now, asphyxia, okay, can lead to hypoperfusion and acidosis if it is long lasting. And this acidosis can lead to multi-organ failure. In the presence of acidosis, the heart and the brain cannot function properly. If asphyxia is not managed in time, it leads to immediate and long-term morbidity. The immediate morbidity can be seizure, okay, very intractable type of seizure may arise within 24 hours, very difficult to control. And long-term morbidity is developmental delay, okay, cerebral palsy, and mental retardation. These are very serious problems. Now, let's talk a bit about pulmonary circulation in fetal life, and what are the changes, okay, after the birth. Now, what is the state of the lung in fetal life? The lung is not working in fetal life. That's why the pulmonary vessels are constricted, okay, and the circulation in the lung is very minimal, as a lung is not the source of getting oxygen during fetal life. The fetus gets oxygen by diffusion through the placenta. During fetal life, the alveoli are filled with fluid, okay, and that fluid means amniotic fluid. The baby is swallowing amniotic fluid, and a lot of that fluid will go towards the lung and fill the alveoli. And remember one thing, this alveolar fluid which is present inside the alveoli is helping the lung to develop, because there is distension of those alveoli which is helping the lung to develop or mature. Ductus arteriosus is open in fetal life. It is one of the very important structure, and it shunts the blood from pulmonary artery to the aorta. Now let me repeat again, lungs doesn't need a lot of blood flow during fetal life, so much of the blood from pulmonary artery is shunted towards the aorta through ductus arteriosus. Now what happens at birth now? Okay, at birth the baby start to breathe. Okay, so lungs will become functional. Okay, the pressure at the time of fetal life inside the lung is very high because of vasoconstriction. Now suddenly the lung expand and pulmonary vasodilation occur, so the pressure rapidly fall. The fluid inside the lung or inside the alveoli is replaced by air now, and the ductus arteriosus closes, as it doesn't have any function left now. Okay, the function is over of ductus arteriosus. So in the beginning, okay, there is physiological closure, and later on there will be anatomical closure of ductus arteriosus. There are certain, reasons for the closure of ductus arteriosus. One, the oxygenated blood itself help to close it, and second, there is decreased production of prostaglandin, so that will also help. Now look very carefully about this picture. Okay, look carefully about this picture, and let's try to know what are the important structure in fetal circulation and what changes occur after birth. Now if you see very carefully, there are three important structures, okay, which are changed after birth. Now, let me show you here. One is called ductus venosus. This ductus venosus is, okay, connecting umbilical vein with inferior vena cava during the fetal life. Now after birth, see there, I cannot see this ductus venosus after birth. Okay, ductus venosus is disappeared. So it is replaced by, or it is converted into ligamentum venosum after birth, and that ligamentum venosum is attached to the portal vein near the porta hepatis. Now another important structure is foramen ovale, which is present in the interatrial septum between right atrium and the left atrium. After birth, it is also closed. And the third important structure is ductus arteriosus, which is present right here between pulmonary artery and the aorta. And after the birth, it will close physiologically in the beginning, and later on it changes into ligamentum arteriosum. Ligamentum arteriosum. So this is very important knowledge for all of you. Okay. Yes, let's talk about what do you mean by apnea. What do you mean by infantile apnea? Now, see here. Now, apnea, the definition is important here. Okay. Please, whoever is talking, I can see their name here. So do not talk while I am taking the lecture because it disturbs everyone. And mute your microphone. Okay. Now, apnea, if a baby doesn't breathe for more than 20 seconds, if a baby doesn't breathe for more than 20 seconds, or sometimes the baby doesn't breathe, for example, 10 seconds or 15 seconds, but with those, pause in respiration, if the baby has bradycardia, cyanosis, pallor, or marked hypotonia, then also we call it apnea. Okay, then also we call it apnea. So apnea has two definitions. One is prolonged pause for more than 20 seconds. Another is less than 20 seconds pause with bradycardia, with cyanosis, with pallor, or with hypotonia. This is also known as apnea. Now there are three main types of apnea in the newborn. They are called central apnea, when the central, the center for respiration, which is present mainly in the medulla, is not responding, or it doesn't develop properly. Another is the obstructive apnea. There is obstruction in the airway passage, so there would be no exchange in the gas. And another one is a mixed apnea. Now, who is Asad? It's causing a lot of noise actually from his side. So please do not do that. Okay. The third one is a mixed apnea, and it's a combination of both central as well as obstructive forces. So three: central, obstructive, and mixed. Now look at this picture. This is highly informative one. This is the primary apnea, and another later on I'll talk about secondary apnea. What is the difference? Now look here. The baby is breathing very nicely here. Suddenly the baby stopped to breathe. Okay, so this is primary apnea. And what happens to the heart rate and blood pressure during this time? The heart rate, okay, when the baby is breathing fine, the heart rate is okay. but heart rate is falling now. Heart rate is falling now. Bradycardia is happening because of apnea. But what happens to the blood pressure? The blood pressure is still normal. Okay, it has not fallen. This is an important finding in primary apnea. Now let's compare this primary apnea with the secondary apnea. Okay. Now see here, what changes can you see? Just have a look here, please. Okay, so you can clearly see the difference. So heart rate falls more drastically than before. Bradycardia is a definite finding. And then look at the blood pressure now. Blood pressure has also fallen. So hypotension occurs in secondary apnea. Secondary apnea is a very late, condition in the newborn. When we do not handle primary apnea well, then secondary apnea occurs. If I do good resuscitation in primary apnea condition, secondary apnea will not occur. So blood pressure will not fall. That shows the importance of resuscitation after the identification of apnea. So I'm sure you are getting what I mean here. Okay. Now same thing is written. Primary apnea, when the baby is asphyxiated, the infant respond with the increased breath rate or breathing rate. But once the baby becomes apneic, the baby doesn't breathe. That is the definition of apnea, which is followed by a drop in heart rate, that is bradycardia, and blood pressure is still normal. We don't care whether the blood pressure is higher or not. The blood pressure is not fallen till now. That is important point. Okay. Now how to treat the baby in case of primary apnea? What are you going to do? It's a very simple type of management. Just stimulate the baby. Just touch the baby. Just flick the sole and rub the back. The baby will start to breathe again. This is the most important treatment of primary apnea. And if oxygen is necessary, you give it. But what you need to do in secondary apnea? Okay. See there? In secondary apnea, because this is a prolonged asphyxia, so there is definite bradycardia, there is definite fall in blood pressure, okay, and the baby is having gasping type of breathing, very few respiration. So I definitely need to do vigorous type of resuscitation, and that resuscitation should be done by bag and mask ventilation, and that is done by ambu bagging. Bag and mask ventilation is necessary in the resuscitation of secondary apnea. Otherwise, the baby will die. Only stimulating the baby may not be enough in secondary apnea. Now, in both primary and secondary apnea, bradycardia is a common finding, but hypotension occurs only in secondary apnea. Okay, that's the point I have been repeating a lot of times, and that shows the importance of this point, because once you start working in a delivery room as a doctor, you need to know these things: when to do resuscitation, when to do just stimulation of the baby. This is very, very important one. Now, how many people we need in resuscitation or during resuscitation or in delivery room? So it's a very simple type of mathematics here. If there is a singleton delivery, means only one baby is delivered, we need 2 people. If there are multiple births, we need more people there, means one number more than the number of babies. Like if there is twin delivery, we need 3 people for the resuscitation. If there is triplet delivery, we need 4 people for the resuscitation. So this is important. And what are the equipment we need for resuscitation? That is heat source, which is already there in the delivery room. You don't need any extra thing there. Ambu bag is necessary for ventilation. If the baby needs to be intubated, we need endotracheal tube, and there has to be certain medications. Now, can I ask you one question? Which medications are very much essential at the time of resuscitation? Just give me the name. Anyone?
Adrenaline or
Atropine.
Very good.
adrenaline.
One is adrenaline or epinephrine.
Vitamin K.
Good.
Vitamin K.
Another is atropine. Atropine. Very good.
Sodium bicarbonate.
Vitamin K.
Dextrose.
Sodium bicarbonate. Very good. Very good.
Dextrose.
Dextrose or glucose. That is also very essential. Okay. And few more you can add. You have already told me the important one. If you answer like this in the exam, you'll get excellent marks. But you can add a few more from your side. It doesn't matter. Somebody is telling me vitamin K. But this vitamin K is not exactly needed at the time of resuscitation. You can give this vitamin K later on also, okay? So I don't consider that as a...
Aminophylline.
Naloxone.
Okay.
Aminophylline.
Okay, good. Aminophylline or naloxone are... I'm talking a little bit about naloxone here. If you think this baby has got, you know, some dose of opioid, which may happen from the mother side, then naloxone is necessary. Otherwise, naloxone is also not considered that much essential drug during resuscitation, but we want that naloxone to be present inside the room. If it is needed, it is needed. You know, we cannot go to outside and buy naloxone when it is necessary. So it should be there. Okay, this is a good way.
Lidocaine.
Yes. The lidocaine is also necessary. Okay. Now let's focus back in the class. Now let's talk about some of the golden rules of resuscitation. What we need to know before we start it. There has to be one leader in resuscitation always. There was one person, probably the pediatrician is that person, and some other people should help him, like some nurses or some other doctors, some junior doctors should help. So if everybody start doing on their own, then it is not a good resuscitation. It is a very haphazard one.
Huh?
Do not talk. Mujib, you are talking here in front of everyone. Do not do that. And follow infection prevention and follow the strict procedure and guideline. That is important point. So let's talk about what are those golden rules of resuscitation. This is known by TABCD. This is a mnemonic which we commonly use. T means temperature. That means you maintain the temperature after the birth. You provide warmth to the baby. Now, how we do that? There are two important ways. Okay, one, make the room warm. The delivery room should be warm already. Okay, it should be it should be more than 28 degrees centigrade. This is the minimum. It should not be less than that. If more, the more is there, it's better for the baby. The second way of providing warmth is wrapping the baby. Okay, just wrap the baby quickly after the delivery. That we have to do. Okay, the second point is maintenance of the airway, and that is done by positioning and suctioning. Positioning and suctioning. Now, positioning means head should be tilted slightly, and if there is some froth coming, if there are a lot of mucus is coming, then you should suck it out. Third is breathing. Now, in the beginning, if the baby is not breathing, you stimulate the baby by just touch. This is called tactile stimulation. We can give that by rubbing the back of the baby, okay, or flicking the sole of the baby. If that doesn't work, then I'll go for a positive pressure ventilation. That is done by umbu bagging. Fourth one is circulation. Now, if the baby's heart rate is very low, it is less than 60. If you find it less than 60, then you start chest compression. More than 60, you don't need to start chest compression. Only bagging or giving good oxygen would help. And last, D is for drugs. And many of the students already told what are those drugs. So this is the rule of resuscitation. Always start T, A, B, C, D. Start with T and go towards D. Okay, so these are the principles. I'll go a little bit quickly here. There's nothing to understand. Just, you know, let's go quickly here. The longer an infant is allowed to go without adequate resuscitation, the more difficult the resuscitation becomes and greater brain damage. Now, I can explain this by primary apnea and secondary apnea example again. In the beginning, probably the baby was in primary apnea, and if I don't do proper resuscitation there, the baby will develop secondary apnea now, and it will be very difficult for that baby to revive because hypotension has already occurred. Now, the person who are present in the delivery room, okay, should be there all the time. It's not like, oh, I'm in the coffee shop. Can I come after 5 minutes, sister? You cannot answer like that, because that by that time the baby is already dead. So you should be present right there at the time of delivery. And the person who is present there should know all the steps of resuscitation. It's not for the sake of presence. He should know how to do bagging. He should know how to put the tube. Okay, so these are important points. Now see there, the person, the personnel or the group or the team who is present in the delivery room should work as a coordinated team. I already explained this. There should be a leader, then other person should follow him. Okay, everybody should not do whatever they want. Otherwise, it will be a very hazardous type of resuscitation to the newborn. You should check time and again what is the response from the patient side. Now let me explain this. You are doing ambu bagging. Through the ambu bagging, you are giving a lot of oxygen to the baby. Now, if that baby was having bradycardia, after giving oxygen, the heart rate should go up. Okay, the heart rate should go up towards the normal. This is called good response from the patient. Another point, if the baby was not responding before, now the baby start to respond, the baby start to move the limbs. This is another response from the patient. And third one, okay, the baby start to cry now, the baby started to breathe. So these are very, very important point we should check while we are doing resuscitation. Another principle, all resuscitation equipment should be in working order and they must be immediately available if we need them. Now, I want to do intubation in the baby, but sister said, doctor, I don't have the tube right now. So what is that, isn't it? So from where we get the tube now? We need to go somewhere else to find the tube, and by that time, the baby may be dead already. So this is very, very serious point. Everything should be there right in front of the resuscitation team. Now, what are the initial steps of resuscitation? Okay, so just like I do this in the class. Okay, please, every student, I'm sure you can see it quite well. Just have a look here. Okay, for a minute or so. See that, please.
दादा paralyze है
Ilyas Khan and Asad, they are talking most of the time. So please, guys, how many times I have to remind you? Okay, now see here. So what are the main steps of resuscitation? This is a bit of revision again. At the time of birth, just clear the meconium if it is present. just check whether the baby is breathing well or not. If baby is crying, that means the baby is already breathing well. If the baby is having good muscle tone or not, if the color is pink or not, and if it's a term gestation or not. All these points are covered by Apgar score. Now, if something is wrong, then I have to go to the second steps. After 30 seconds, I need to do all those things and go to the second step. Provide warmth, position the baby, dry and stimulate the baby just by touching, and give oxygen as necessary. Oxygen may not be necessary to all the babies here. After that, you evaluate the respiration, whether it has come back, what is the heart rate, and what is the color of the baby, and you decide accordingly. If the baby is not breathing still, you definitely go for positive pressure ventilation, which is done by ambu bagging. And if heart rate is less than 100, then also you go for positive pressure ventilation. Now the last step is, if the heart rate is constantly decreasing, now it reaches less than 60, then you have to go for chest compression and you have to continue positive pressure ventilation. But if the heart rate is rising more than 60, then you don't need to go for chest compression anymore. Just continue positive pressure ventilation. Okay? And you decide about administering the. Now see that this is the way to dry the baby. Dry thoroughly. Okay? Remove the wet linen or wet cloth and reposition the head. We have already learned how to do that. So this is another steps of resuscitation. Now look carefully here. This is the way to stimulate the baby. The stimulation can be done by flicking the sole. This is how you flick the sole here. Okay, flicking the sole, and this is rubbing the anterior abdominal wall. Okay, or you can also do the same thing on the back, rubbing the back, rubbing the anterior abdominal wall, or flicking the sole. These are the way to stimulate the baby, and mostly this works. Okay, the baby start to cry after you do these things. Now have a look here. Okay, what's going on? This is giving oxygen to the baby. This is by face mask. Okay, this is by face mask, and it is by the tube. This tube is also effective. This type of oxygenation may help the baby. Okay, it may help the baby. Now let's talk about bag and mask ventilation. Bag and mask ventilation. This is also known as positive pressure ventilation. So what are the indications for bag and mask ventilation? Please have a look here. There are the certain indications for bag and mask ventilation. Okay. These indications are, if the baby is not breathing or if there is a gasping respiration, I definitely need to go for positive pressure ventilation by bag and mask. If the heart rate is less than 100, you already know this, then bag and mask ventilation is necessary. Okay, it is necessary. And if the color remains cyanotic despite 100% oxygen, then also the oxygen has to be given with pressure, and that can be done by ambu bagging. So these are the different ways. Now, what are the equipment we need for resuscitation by bag and mask ventilation? We need ambu bag. Okay, this ambu bag has a certain part, which is bag and mask, and this bagging or bag can be of different type: anesthesia bag and self-inflating bag. Usually self-inflating bag is commonly used during the resuscitation. This anesthesia bag is given during general anesthesia, which you learned later on when we talk about anesthesia subject. I'm sure you are learning right now, especially the 8th semester students. Okay, when you reach 8th semester, you will learn about that. Now see here, look at this picture. This is called self-inflating resuscitation bag. Okay, have a look here. Okay, now it's okay, it is working, so I don't want to do anything other thing right now. Okay, now see here, this is the oxygen source which is coming from the wall. This is the bag. Okay, this is the main part of the bag. This is called reservoir. Okay, this is the reservoir, and here is the mask. This mask is attached to the baby, and here is a valve. If you apply too much pressure, or if you squeeze very hard on this bag, then this pop-off valve will open, and that pressure will not go towards the lung of the baby. So it is a safety measure regarding the resuscitation bag. So this is how AMBU bagging is done in the newborn. Okay, now a little bit about what are the size of the bag, okay, and what are the safety features. The size of the bag, it depends on the neonate size. For example, if the baby is very small, like a premature baby who is born with 1.5 kilo, then maybe small bag is enough, which is about 200 to 250 ml. But a big baby, for example, baby of diabetic mother, he needs a bigger bag. So this is how we judge it. Oxygen, usually we give 100% oxygen, which is a pure oxygen. And regarding the safety feature, you don't squeeze very hard. Okay, if you squeeze very hard, the pressure will be higher and the pop-off valve will open automatically. Okay, now I will talk about how to apply these mask and what are the different types of the mask. Okay, now see there. So this is called anatomical mask, and this is a round mask. Now this mask has to cover nose and the mouth very tightly. Nose and mouth both has to be covered very tightly by the mask. Okay, this is very important point. Now look here, look at this picture. Okay, this is a rounded type of mask. Okay, and this is another type of mask. Here it is covering, okay, it is covering nose and the mouth both, and it is forming a very tight seal around the mouth and the nose, so that when you squeeze, when you're giving oxygen, the oxygen should not escape from the side. This is a very, very important point. Same thing here. There's nothing to discuss in this case. Okay, now what are the correct and incorrect way of applying this mask? Okay, just have a look here, please. See this? Okay, what is the correct and what is the incorrect way of applying this mask? Now look at this is the correct one, because a good part of the nose and whole chin is covered by the mask, so that no air will leak from the side. But this, see there, I can still see a part of the chin which is not covered nicely, so the air will leak from here. Okay, air will leak from here, and also it is going a little bit towards the eye as well. So this mask is too big for the baby, so this is not a correct one. And this mask is very small, it is too tight. Okay, so this is also not good. So the first one is the correct size of the mask. It is all about a practical point. When you start working, okay, you yourself know which one are the correct one. Before you start the positive pressure ventilation, okay, you need to check whether that bag is working or not, whether the bag is in good shape or good condition or not. Sometimes there is leakage from the bag itself. Okay, sometimes the bag is not working properly. So how I know that? It's very easy. Just put that bag on your palm. Okay, the mask should be kept tightly on the palm, and you squeeze the bag, and then you squeeze the bag. Then you judge. Okay, you judge these different things. Do you feel pressure against your hand or not? A good pressure has to be felt if the bag is working properly. Can you force the pressure release valve open or not? For example, I have squeezed very hard and I want to make sure whether that valve is still working or not. If I squeeze very hard, that valve should open, then only it is working well. If it doesn't open, that means it is a defective one, because all that pressure will directly go to the lung and can cause pneumothorax in the baby. Okay, so if you have a manometer, manometer means it's the instrument which measure pressure. If that pressure is showing 30 to 40 centimeter of water, that means it's the optimum pressure. We should not go higher than that. Now see there, the point which I am discussing right now is nicely shown here. This is a tight seal you have made on the palm of your hand. This is the umbu bag. You are squeezing the bag and checking everything, whether it is working or not. So this is the way. Now, if it is not working, then this may be the problem. There may be a crack or leak in the bag. Okay, the pressure releasing valve may not work properly, or probably the patient outlet sufficiently blocked, or the mask is not applied properly there. So these are the practical points. So what I'm saying here, all the time, is check the bag properly before you use it. Otherwise, it may be too late. By the time you start resuscitating the baby, there's no other bag, and the bag which you have is defective. Now you don't have any options left, because even few seconds are very critical during that time. So make sure your bag is the right one. Okay, now what do you need to check before assisting ventilation with the resuscitation bag? So these are the different points. This is like a revision slide for you. Select the appropriate size mask. It depends on the size of the baby. I've already explained this point to you. If the baby is very small, like a premature baby, very low birth weight baby, then the mask size would be smaller. Okay, make sure the airway is clear. Now before I do resuscitation, I need to make sure the airway is clear. Position the baby's head by slight extension, and that slight extension is again obtained by positioning a towel, a folded towel, on the shoulder of the baby. Okay, I have explained this point already. And position yourself at the bedside. Okay, the correct position is you stand towards the head end of the baby, not towards the foot end, because we need to do resuscitation from the head end. Now what I'm talking here, please have a look at these different pictures and try to know. Please do not talk. Okay, I'm getting some noise here. Please listen carefully and look here. See this? These are the correct size face mask which covers mouth, nose and tip of the chin, and there should not be any leakage of the air from the side. This is important point. Now, how to correctly extend the head? What do you mean by that correct extension? See that the piece of folded towel is kept underneath or beneath the shoulder. This is the way. Okay, now you have already seen how it is done. Now how the doctor or the nurse or the resuscitator, how should they stand on the side of the baby? Now see here, this is the correct way. This is the correct way of standing towards the head end of the baby. Okay, this is also the correct, because the examiner is still standing towards the head end, but this is the incorrect way, because the resuscitator is standing toward the foot end of the baby. So they have to extend their hand, and they are a little bit far away from the resuscitation side. So this is incorrect one. Okay, now this is already explained, so I am skipping this. This is the correct way of keeping the mask. I already told you, good size of the nose, whole of the chin should be covered by the mask. Then you should catch the mask with your fingers like this, and with another hand you will squeeze the bag, so that there will be no leakage of the air from the side. This is a very, very important point. Now what happens if the air is leaking from the side? Okay, the air will not go to the lung, and you are thinking the air is going to the lung, but actually all the air is leaking from the side. to the external environment. What is the use of that type of resuscitation? So make sure your bag or mask is tightly fitted on the baby. Okay. Now, how hard to squeeze? This is very important practical point. How hard to squeeze? Now, the best indicator for how hard to squeeze is how high the chest is rising and falling. If you are giving good amount of air, okay, the chest should rise and fall significantly, and at the same time you auscultate both sides of the lung. There should be entry of air. You can hear that. These are called breath sound. Okay, you can hear that. And third point, in the beginning, if the color of the baby is blue or if the color of the baby is pale, then that color should go toward the pink color. Pink means normal. Pink means oxygenation. And one more thing, you are counting the heart rate. The heart rate should slowly go higher and higher. Okay, in the beginning probably the heart rate was low, but right now the heart rate should rise up and up. And if there is pulse oximetry which is attached, that pulse oximetry should show good amount of oxygenation to the baby. So these are the different way which will tell you that you are doing resuscitation quite well. Okay. Now another important point is what is the rate of squeezing the bag? How fast in 1 minute? How many times in 1 minute? Now the answer is very easy here. What is a normal breathing rate or respiratory rate in a newborn? Okay, it is 40 to 60. 40 to 60. So that is the squeezing rate of the bag. So you squeeze the bag, okay, or you can count also 1, 2. In 1 you squeeze, in 2 you release, 3 again squeeze, 4 release, 5 squeeze, 6 release, like that. If you do like that, you don't need to exactly count how many times you have squeezed. It will automatically be in the normal range. But if somebody asks you what is the squeeze rate, it is 40 to 60 per minute. Now some points are still left behind. Okay, we are coming towards the end of the topic now. Now what to do if the chest is not rising with each squeeze of the bag? What's the problem there? What can you do during that time? Now as a doctor, I need to know certain things. Maybe there is inadequate seal formation on the mouth and nose of the baby. Maybe the air is leaking from there. So you reapply the mask again to the face. That is quite easy to do. Second one, who knows, the airway may be blocked in the baby. Okay, maybe the neck is flexed. That's why the airway are bent. Maybe there is a lot of secretions in the airway. Okay, so in that condition you reposition the head and you go for suction of the secretions. The third point, probably you are not squeezing the bag enough, so increase the pressure a little bit. Or you can do one thing, you can intubate the baby and connect that ambu bag directly to the endotracheal tube and squeeze. If you do that, all the air will go directly to the lung. It really helps. But having said that, you should know how to intubate the baby. Then only you can do this. Okay. Now, how you know the baby is improving? Okay. Just now I talked about this, so this is a bit of revision for you. Okay. Improvement is indicated by 3 important signs. Now see there. Okay. It is indicated by 3 important signs, and they are increasing heart rate. If the heart rate is going up and up, if the baby is being more pink or color is improving, and if the baby starts to breathe spontaneously or the respiration has a comeback, then we know our resuscitation is quite good. Okay, then that is the time to stop positive pressure ventilation and giving only oxygen. Now another important point here, when you do prolonged type of positive pressure ventilation by bag and mask, okay, what else you need to do? Because a lot of air will go into the GI tract, and it will distend the stomach. The stomach will push the diaphragm upwards, and it will disturb the expansion of the lung. So what can we do, okay, in that situation? So we are going to insert nasogastric tube or NG tube. We all know this NG tube, isn't it? In surgery, probably you have already done those practicals also. Now, NG tube, when we put through the nose, okay, into the stomach, one of the tip will enter into the lumen of the stomach, okay, or cavity of the stomach. Then, if we connect the other end with a syringe, then we may aspirate the gases from there to really help the baby during that time. Now, another important thing, this gas will also regurgitate the gastric content, which then be aspirated during ventilation. And this aspiration can lead to aspiration pneumonitis, which is considered a very severe type of pneumonitis. Now, another important concept student has to know is how to insert a nasogastric tube. To insert a nasogastric tube actually. So what are the equipments? We need 8 of a French feeding tube and 20 ml syringe. So very small feeding tube is necessary, and we need 20 ml syringe to attach on one end of the NG tube. Now first we need to make sure how much to insert inside. So we need to measure the length, and that is done by measuring the distance from the bridge of the nose, see here, bridge of the nose to the earlobe, and from there to the xiphoid process. So distance from the bridge of the nose to the earlobe, and from the earlobe to the xiphoid process. So let's show you one picture, and it will make it very clear to you. See this? This is the bridge of the nose. From the bridge of the nose till the earlobe, and from the earlobe to the xiphoid process. This is the total length you are going to insert from the nose, and the tip will reach the stomach. Now, another important point is how to make sure the tip reaches the stomach and not in the lung or airway. Now, you need to auscultate, okay, the epigastric area, and at the same time push a bit of air through the syringe attaching to the other end of the NG tube. And if you hear a loud gush of air into your ear by stethoscope, that means the tube is in the right place. If you do not hear that, if that noise is not there, that loud, or on aspiration you get something else, some a little bit frothy type of fluid or something, then take out the whole tube and try to put inside again. Okay, that you always can do. Now another one, you are doing positive pressure ventilation, but the condition of the baby is not improving, or the lungs are not getting adequate ventilation. So what may be the reason? This is a very, very important practical problem. So some of the reason may be mechanical blockage of the airway by meconium or mucus in the pharynx or trachea. Meconium is an important substance here. Importantly, the thick type of meconium, or we call it particulate meconium. Okay, that is one of the important reason for blockage of the airway. Another is choanal atresia. This is a congenital anomaly where the posterior part of the nose or nasal cavity is not communicated with nasopharynx. It is blocked. It is not formed. That opening is not opened at all. This is a congenital anomaly, and there is severe obstruction. If bilateral choanal atresia is there, this is a big problem. Pharyngeal airway malformation, okay, and laryngeal wave are other conditions which can cause mechanical blockage of the airway, and the lungs cannot get proper ventilation. Another important group of causes are impaired lung function. Somehow, okay, you are doing the ventilation, but lungs are not getting enough air because of pneumothorax. Presence of free air in the pleural cavity, and that free air is pressing the lung. It is collapsing the lung. Congenital pleural effusion, same type of mechanism. But in this case, there is fluid now, and that fluid is collapsing or compressing the lung. Congenital diaphragmatic hernia. Some of the intra-abdominal organ like stomach and intestine are herniated up in the thoracic cavity. Now, during the resuscitation, okay, we all know stomach is distended by air. So that stomach or those intestine will further, compress the expansion of the lung. This is a big problem. So in case of congenital diaphragmatic hernia, you put endotracheal tube and directly connect the umbu bag with endotracheal tube and continue the ventilation. This is always done. Pulmonary hypoplasia means lungs are not properly developed. They are smaller in size. And congenital pneumonia can happen, especially if the mother is having premature rupture of membrane or chorioamnionitis. So the baby can have or be born with congenital pneumonia. This is a consolidation formation inside the alveoli of the lung, and ventilation will not be proper. Now, what are the indications for endotracheal intubation? In which situation we go for endotracheal intubation during neonatal resuscitation? 1. Prolonged positive pressure ventilation required. Now, what does that mean? Okay, so sometimes the baby needs prolonged ventilation. We cannot discontinue it. Okay, so during that time, intubation is always essential or necessary. You cannot always do bag and mask ventilation. It is difficult. Your hand would be tired. Your assistant's hand would be tired. So put a tube there. Okay, fix the tube, attach the bag, then both of your hands are free, and you can give the ventilation. Now, when bag and mask ventilation is ineffective, a perfect example I can give is congenital diaphragmatic hernia. Now, actually, bag and mask ventilation is contraindicated in that situation because a lot of the air through the mask will go into the GI tract. That means in the stomach or colon or intestine, you can say. So they are present in the thoracic cavity in this condition. So they further compress the expansion of the lung. This is a big problem. But if you put endotracheal tube, nothing like that will happen because all the air will directly go into the lung. Tracheal suctioning. In case of meconium aspiration syndrome, or when the baby has aspirated meconium, but till now the syndrome has not occurred, or it has not reached the lung, let's say, then it can be sucked out through the endotracheal tube. So what we do, we put an endotracheal tube there, okay, connect the end of the endotracheal tube to the suction machine and apply gentle suctioning so that we hope whatever is causing obstruction there would come out, importantly meconium. So when diaphragmatic hernia is suspected, I already gave you the reason. Now we are reached towards the final part of this big topic. What are the contraindications of bag and mask ventilation? In which situation you cannot do it? 1. So many times we discuss congenital diaphragmatic hernia, bag and mask ventilation is contraindicated. But remember, you may not be able to know that in the beginning. But when you are doing bag and mask ventilation, the baby doesn't improve, and you should immediately pick that out. Okay, do not continue it even the baby is not improving. That will be disaster. Another one, meconium strain depressed baby. Now this is a controversial statement here. Okay, now these days the guidelines tell us that even in the meconium strain depressed baby, all the steps of resuscitation would be just like the normal just like the baby who is not aspirated any meconium. What I mean here, the depressed baby because of some other reason, for example birth asphyxia. Okay, so whatever type of resuscitation you do there, you do the same type of resuscitation in meconium strain depressed baby as well. Having said that, some of the pediatricians think there is already presence of meconium, okay, in the airway. So if I do bag and mask ventilation, I'll further push that meconium deeper down. So when I put endotracheal intubation, I can suck that meconium out and then continue ventilation. So this is their opinion. Okay. Now at the end, please go through these questions. These are very, very important questions which I have compiled from the whole topic, and if you confidently can solve them, okay, you should think you have done the good job. Okay, thank you very much.